Okay. Hi.
Hi. So last time we did a consult with me, we talked a little bit about when you examine a patient and it was a patient that actually had a rectocele.
Yes.
And since that episode, I've gotten a few questions from patients about rectocele.
Okay.
And so I want to go a little bit more into rectocele, what type of patients get it, how they get it, what it is exactly, so forth and so on.
Okay. Erectus is a weakness in the pelvic floor muscles that causes some bulging into the vaginal canal of the rectum. And so there's relaxation there, and that's either weakness of the muscles or damage to the muscles, usually from childbirth. But it very frequently occurs just after menopause because of lack of estrogen. So there are lots of things that contribute to this. And it's a relaxation, a bulging that patients feel. And sometimes it's difficult for them to empty their bowels because when they put pressure on the pelvic floor, as they're having a bowel movement, it gets redirected almost in front of the rectum and makes it functionally difficult to have a bowel movement. And what patients have to do sometimes is do what we call splinting, where they will put two fingers in the vagina and support the posterior wall of the vagina and direct the stool to be able to come out through the rectum. So a rectocele is one type of pelvic floor relaxation pathology.
Okay, I have a question. A rectocele, okay, so after someone delivers a baby, though, can they get a rectocele?
That can be one cause of them having a rectocele.
And how does that happen?
Either by stretching the tissues so much or damaging the tissues so they tear, or just genetically they have weakness in fascial tissue. And with age and time and gravity, that weakness gets worse. And we can see it only when examining a patient, but there are various degrees of it. And most of the time, it doesn't need to be treated, but sometimes it's very severe and needs to be treated.
Okay. What symptoms do people have besides the one you just said if they have rectocele? How would you know?
A feeling of pressure, of fullness or bulging basically from the vaginal opening.
Okay. So does it go along with prolapse?
Yes, it does.
Do the two go hand in hand?
Yes.
Most of the time?
It's a different way of looking at it, but it's the same thing. There are three different levels of pelvic floor relaxation in terms of the anatomical place. One of them is the posterior aspect of the vagina, and that is a rectocele. If there's a defect there, that's a rectocele. The uterus itself can prolapse down, and that's a uterine prolapse. And then more commonly is the anterior wall of the vagina is weakened, and the bladder prolapses down into the vagina. So there's some bulging anteriorly. And then, of course, all of those three things can happen at the same time.
Okay.
So they're all same pathology, genetics, pregnancy, childbirth, or we even see it with people who have not had children that have been bodybuilders. So they've been, for their lifetime, putting a lot of increased pressure in the abdomen by lifting weights. And so we see patients that have never had children that have prolapse. And rectocele can be one of those things. Why should it be rectocele as opposed to a cystocele, which is where the bladder comes down or the uterus is coming down? That just varies in terms of the weakest link of the chain.
Okay.
And they all have essentially different treatments.
So why would someone get a surgery for rectocele?
If it was symptomatic, meaning that the symptoms of pressure or the difficulty with bowel movements were bothersome to the patient, and that's not going to get better with time.
Yeah.
So surgery is one option.
And is there any other way to treat it?
Yes. Pessaries can be used.
What's a pessary?
A pessary is a ring of a rubber or a synthetic ring that is placed in the vagina, and because it's a sort of stretchy or has a memory to it, it expands to fill the vagina and support the rectum coming through or the bladder coming through. But that's unfortunate for people to have, because we use those generally for patients that are much older that are not good surgical candidates.
Okay. So that's not something you do like on a 44-year-old.
It could be, because if that's all that they had, if they didn't have a cystocele or there wasn't any uterine prolapse and they had this bulging, then that's a very reasonable thing to do as surgery.
But you said it's unfortunate.
But
why? Is it just uncomfortable or?
No,
why is it not a good thing to do? Or why is it just for older patients? Is there something about it that
because surgery is dangerous, and the longer you go on without surgery, the increasing age of patients increases the risk of surgery. So surgery is the usual treatment for this if it's symptomatic. If the patients are not good surgical candidates, they've got other medical issues, then a pessary would be
okay. So a pessary is used only for people
that aren't good surgical candidates. If it's bad enough to be treated. But there's another aspect to the rectocele, that it may, being just one type of pelvic floor relaxation symptoms, that vaginal laxity, lack of sensation with intercourse, other concerns that people could have and need to be treated.
Okay.
Tightening of the vaginal tissue.
And that would be with surgery?
Yes.
Great.
I think another subject is a cystocele or uterine prolapse that I think perhaps we could do as a separate.
Yeah, we can do those separately. Okay, thank you.
You're welcome. Well, thanks for listening. We're getting really good feedback. We'd really appreciate a review on Apple Podcasts, Spotify, or wherever you're listening. Thank you. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. The Vagina Doctor Podcast. It all starts here.